All right. So to start the discussion on cardiac emergencies, we're going to look at one of the most common reasons for these diseases and conditions to start up, which is atherosclerosis. So this is basically a disease of the vessels. Old school, we call this the hardening of the arteries. It's that laydown of the cholesterol deposits, other debris, anything that's affecting that narrowing of that vessel. So we're not getting the adequate blood flow beyond it. Usually our cardiac symptoms don't show up, or the cardiac damage from the impaired perfusion, not to about 70-75% narrowing or stenosis. So what does that mean? Why is that important to know? It tells us that even people who are quote unquote healthy, unless you have had a heart cath to see how your vessels look, you could already have some atherosclerotic disease and you'd be doing fine. I mean, a 30% narrowing, you probably don't even have any symptoms at all. So that by the time our patients are really having cardiac symptoms, especially of coronaries, ACS, STEMIs, et cetera, they've got established disease. You just don't have a STEMI with only 20% narrowing, okay? And then we got the risk factors now. Anything, we've learned about these in BLS and American Heart. We've got things we can change or improve, and there's things that we're just born with, like our family heritage, our genes. We've got our comorbidities. We can hopefully take care of our diabetes, our blood pressure, take better care of ourselves, things like that. So we got modifiable and non-modifiable risk factors, right? So actually having coronary disease, we got some significant stenosis going on. I'm gonna make your life really easy for this exam. We're gonna go ahead and throw out the ischemia. That is not gonna be an emergency on this exam. Yes, it is an emergency in real life, but ischemia is just an imbalance. We can reverse ischemia because tissue is not changing yet by increasing the oxygen that's getting to the tissue. So it's reversible. The other reason this is not on the exam is because the EKG is not always useful for ischemia. So what's the one thing we all can do? We all do EKGs, depending on what your guideline is, usually within 10 minutes of arrival, we're doing EKG and getting someone to look at it. And with ischemia, there's not always changes showing up, okay? So ischemia is not going to be the exam. Injury and infarct will be on the exam because they will have a positive EKG change, and that is something that all of us can detect for pretty much within minutes of someone arriving to the department, all right? Injury is now we're actually having damage from that lack of blood, of oxygen flow to the tissue, and infarct is that dead tissue we don't get back. Okay, hopefully our body will kind of remodel around that area and maybe have some corollary circulation to it, but you're not getting that tissue back. Your heart's gonna have to work a little bit differently from that point forward. Okay, so injury and infarct will be on the test because they will have a positive EKG. Now, stable angina won't be on the test either, but unstable will. Unstable is on the test because that is a change from a chronic condition. A lot of people have stable angina. They take long-acting nitrates at home. That's like your Imdur, your isosorbide, the long-acting nitrates to help keep those vessels open. And those are the ones that might also take a nitroglycerin pill, and it helps relax the coronaries if they're having that imbalance between supply and demand, okay? But unstable angina is a worsening of this pattern. Now their 3 nitros don't work anymore. Now their chest pain is persistent beyond like 15, 20 minutes or longer. Maybe now their chest pain is starting and they're not even exerting themselves. They're not even asking their heart's not even asking for more oxygen, and they're having true anginal equivalents now. Okay, so this is in other words, if there's a stable and an unstable angina patient both present, I need to take this person first because they may not be able to rebalance that O2 supply and demand and wind up with an infarct. Okay, so unstable angina is the emergency of the two. STEMIs and non-STEMIs. STEMIs will be on the test, non-STEMIs won't. All right. The reason a non-STEMI won't be on the test is because the criteria for non-STEMI is a normal EKG, but an abnormal troponin. The troponin is proving that there's damage going on, and they're having an infarct. It's just not an ST elevation infarct. And across the US, not all of us are doing rapid troponins. There's still hospitals out there that you have to send your troponin off to the lab, and you may be lucky if you get the result in 30 minutes, okay? Some places, including some places I've worked, we did bedside and we had it in 5 minutes, okay? But that's not standard of practice yet, okay? So the only ones universally for the CEN that we can pick up on right away would be the STEMIs, where we actually see it on that rapid EKG, okay? The symptoms for these heart attacks, they don't change. They're textbook. We know them all. We ask about them. Every chest pain that comes in. And remember, we may even have the diabetics or the females that have very atypical symptoms. Okay, so we're going to keep our index of suspicion pretty high if a person has the risk factors, if they have got the comorbidities, things like that, and we're going to err on the side of caution. All right. As far as a STEMI, it's going to be straightforward. ST elevations. Left bundle branch block will not be on the exam. Again, there's a reason for that, because it has to be a new left bundle branch block. And has everybody had an EKG before to know if they had it? No. Do all hospitals have rapid access to their last EKG they had? No. Some places that does spit out their most recent one, if you do one, some places don't do that. Some places still have to get medical records to send them their old chart, believe it or not. Even though it's digital, they have to dig into the digital record to find it. So the only one that's universal in this test will be STEMIs, because we're doing that rapid EKG and we see those ST elevations going on. In that case, the troponins just confirm it for us. Okay, there was a day we diagnosed heart attacks without lab enzymes. So again, this exam, making your life easier, is going to focus right in on the most easy to detect, rapid ones we can all do. So in this stuff I sent you, or if you had to download the forms, you've got this color EKG if you want to look at it while we look at it on the screen here. What we've basically done is taken several different ways to learn or to put into our working memory how to look at these EKGs. You will not see an EKG on the test. Okay, there will not be an EKG on the screen of the computer that you're taking the test on. The only way EKGs are presented is they give you a verbal description of where the ST changes are. Okay, so that's why you have to have this kind of picture in your mind as you're reading the test question. All right. This is also one of the things I recommend that you write down on your piece of paper during the exam, or as soon as you start the exam, if you want to go ahead and draw an EKG. So go ahead and draw your 3x4 EKG, label your lead names, so that when the STEMI question does come up, and this is another high frequency item, especially inferior MIs, you already have it on the paper there in front of you. You can go ahead and look at it and say, yep, does this match up with these particular zones here? All right, and how are you going to prep for that? Just the short term before the test, maybe the week or two before, you'll practice drawing this several times at home on blank paper, and eventually be able to do it from memorization. Okay. So I've taken the phrase here, I see all leads, and that's going to remind us I for inferior, S for septal, A for anterior, and L for lateral. And then we've color coordinated the different words. So letter I, red, and made the inferior boxes red also. Those are 2, 3, and AVF. The blue S is for the septal zone, and that's V1 and V2. That orange, I don't even know what color that is, kind of orangish, I guess. That's our anteriors, and that's V1 through V4. And then the green L for lateral, we made 5 and 6, and then wrapped back around to lead 1, made those the lateral ones, the green ones. You know, I usually forget AVL a lot of times myself. I'm guilty, but as long as you get 5, 6, and 1, you're going to get the answer correct. So the criteria for a STEMI is you have 2 or more boxes in a zone with ST elevations. Okay, so for inferior, it could be 2 and 3 or 3 and AVF. It doesn't have to be all 3. Minimum is 2. 2 or more adjacent boxes in that zone. All right. So it's just a matter of practicing drawing it, writing out the verbiage for it also, like here. Actually, if you want to actually practice writing, you know, which zone and then the leads that comprise that zone, and then practice drawing your picture also, and you'll get it. You know, the only one I carry around in my mind all the time is 2, 3 AVF. The other ones I'd have to think about for a minute. It's just not something I carry around and use daily. All right. And typically we do see a lot, at least the inferior MIs really get our attention, right? All right, the bottom of the EKG. Oh, and the other thing, the only thing they're going to refer to EKGs for on this test is for STEMI identification. They're not expecting you to be a cardiologist. They're not telling you about poor R wave progression, repolarization abnormalities, LVA, none of that. It's just about where's the ST elevation at, okay? So you've got to know your 4 major zones, inferior, septal, anterior, and lateral. All right, as far as the why, we'll get there in a minute because we'll come back to that after I tell you about the rhythm strip. So on the bottom of your EKG, you've got a 6-second strip. This is the same as lead 2 here, but instead of just only getting a picture of it for about 1.5 seconds, you get a full 6 seconds of it across the bottom. The reason we do that is because sometimes some of the irregular rhythms don't always show up in the small box, like an AFib sometimes. You need to see it all the way for 6 seconds to see if there's some pattern or something going on there, okay? So this is called your rhythm strip. This is the same strip whenever you get an ACLS question, okay? In ACLS, we typically look at lead 2. This is that same lead. Now on the CEN exam, you can get rhythm strips, all right? If you see a rhythm strip, I've seen several in the exam. They actually have a picture of an ACLS strip on your screen. They're asking questions about ACLS stuff for that, okay? We're not doing STEMIs just off one lead. You can't, because you have to see it's 2 or more boxes, all right? So if you're looking at one of those ACLS strips and you need to calculate the rate to be able to answer the question, here's a little tool for you. If you know this, awesome. If not, maybe something you like and take with you clinically. So you look along your rhythm strip and you find the QRS that's closest to the dark red line. So in this case, this example, I've pointed out this one. This will be my first one, all right? And all you do is you count how many big boxes, how many dark lines until the next one. And this was a great example because this one lined up pretty much right on it, and so did this one, all right? And you just remember these sequence of numbers. If it was 1 box over to the next QRS, that rate would be 100. If that QRS came here, that'd be 150. But in this case, it landed here, and the 3rd box lines up with a rate of 100. So this heart rate is a rate of 100. I know it's a little bit off the line, but again, the ENA, the CEN does not go splitting hairs, chasing zebras or gray zones. So they're not going to ask you, like, what is this guy's rate? Is it 98, 99, 100, or 101? That's not a fair test question, okay? It might be more like, what's this approximate heart rate? 120, 105, 101, or 95. You'd be like, well, 101 is the closest to that, okay? The nice thing about this number sequence, you only need to know the first 5 numbers, all right? 300, 150, 100, 75, 60, just practice writing them. You don't need to know these ones. Why? Because anything less than 60 is bradycardia, and we treat these all the same based not on the number, but on the patient's symptoms. So whether the heart rate is 37 or 50, the treatment is not different because of that number. The treatment is only how is that affecting the patient. So if a patient's looking crummy at 50, I need to do something. If they're looking great at 37, I don't need to do nothing. Now, I know in the real world, if their heart rate's 37, yeah, you're finding the crash cart, you're making sure the pacer pads are nearby, but you're not doing interventions solely on the number, okay? The other cool thing about these numbers, these first 5, it has some of your ACLS decision points built in, okay? You've got 150 built into here. That's your SVT defining number. You've got 100, that's your tachycardia number. You've got 60, that's your bradycardia. That's cool, all right? How do you memorize these? You just start writing them down. 300, 150, 100, 75, 60. Flip the card over, write them again. 300, 150, 100, 75, 60. That's all you need to do. So that's how you calculate. Because if you, matter of fact, if you want to look in the back of the book, I've given you some practice strips back there just to practice on yourself. And I've left the answers blank. The answers are in the back though. Sometimes those rhythm strips, depending how big the strip is or how small, it's hard to tell the exact rate. But this method will never fail. As long as you can see the dark lines, you can count your boxes and see what your rate is, or at least get you really close to be able to make some treatment decisions. Okay. All right. So again, on the test, you're going to see them written in a verbal format. Okay. And practice doing that. Okay. Let's see. Here's a real EKG for you. So we've got an inferior MI here. These eyes probably go here first. See these large ST elevations here in lead 3. So the inferior zone is 2, 3 AVF. Do I have something in 2 also? Yes, I do. AVF, yes, I do. So I've got my criteria for an inferior. There's some other stuff going on with some depressions in other places, but this is my big concern, this inferior component here. All right, testing. We're going to come back to the right side of the posterior MI in just a minute. I'm talking about the right side of the heart. So just hold that thought there because I know I'm skipping right over that one paragraph. Test-wise, we do a lot of tests on these patients. Your most useful, most specific lab test will be your troponin level. And again, there's not many lab numbers on this test. Troponin is not even one of them because there's variability. One place I worked, we did bedside troponin. Actually, one place I worked, we did both. Our bedside reference range was not the same as our lab reference range. So not fair for the BCN to ask you specific values. They'd have to tell you what the normal range is, and then tell you what you got, and then you decide, okay, it's normal or it's out of range. There are a few people that have chronic troponin elevations and they're not having a STEMI. And two of the largest groups of that are your CHF patients or your renal patients. Now, if the exam wanted to test your knowledge on that, they'd have to tell you about their baseline or their background. Okay. One of the other rules about this test is you never assume anything unless it's statistically overwhelmingly true. Okay. Like I told you, the number one cause for acute kidney injury statistically in the ER is a fluid problem, and they get fluids. Yeah, there's some people who have kidney damage from other things, from kidney stones, hydronephrosis, etc. That's not the majority. All right. So people having elevated troponins is the minority, actually. So this patient's having a STEMI. I need to get them into the cath lab. That's their definitive treatment. Okay. They can actually go into the vessel, see the narrowing, do what they need to do, and they can see the vessel actually open up and return that blood flow. So PCI, which stands for percutaneous coronary intervention. Some places it's PCTA, percutaneous coronary transluminal angioplasty. They all mean the cath lab. Okay. Now, if I can't get them into the cath lab in 90 minutes, okay, then I need to consider giving them TPA within 60 minutes. I'm sorry, within 30 minutes. So the setting for this is usually a smaller, more rural hospital that doesn't have a cath lab, and you're transferring patients to the bigger mothership hospital, and you know your transport time usually exceeds that 90 minutes. So even though you're still getting the helicopter en route, you're still getting your lab tests or your ground, or you're making calls for the receiving cardiologist, you need to be thinking, while we're doing this, should we be looking at giving TPA? Because that might actually give them some benefit and buy them some time till they get to the cath lab. All right, and having the TPA does not preclude going to the cath lab. Just like when we do our strokes and they go and do the stroke interventions, the clot retrievals, the thrombectomies, things like that. Just because they got TPA, if they still meet criteria to go to specials, they're still going. Having given TPA does not preclude the definitive treatment if they meet criteria for it. So same thing with our hearts. All right. After the heart attack, or even some of our angina patients that walk in, we have opportunities for education and teaching them. Sometimes we have to talk to them about their meds, again, like the nitroglycerin or whatever. Some of these patients, especially with stable angina, have had that nitroglycerin forever. They don't use it hardly. And so the time they need it, it may actually be expired. So we might have opportunities to explain to them, like, if you take this, Mr. Smith, you should feel like tingling on your tongue. It might give you a headache. Of course, hopefully relieve your chest pain. We want to talk about storing it. We don't want to store it in the glove box, in the South or in the West, where it gets really hot in the summertime, because that heat will kind of break down the drug some. Drugs we're going to use. All right, we're going to give oxygen. Now, our current recommendation for oxygen from American Heart is we are happy with an O2 sat of 93 or 94%. So the O of MONA, which is our old standby, morphine, oxygen, nitro, aspirin, the O is kind of fallen out of just being the knee jerk, we're going to do it for everybody. Let's look at their oxygenation status and see if they actually need it. All right, 20 years ago, you came with chest pain, you got oxygen automatically. 93, 94% is all we need right now. All right, they are getting aspirin. That is a standard. And your standard dose is either, if you give 1, it's 325. If you get 4 of the 81s, it's 324. All right, the ENA will never ask you to split that decision on what's the right dose. It's 324 or 5. Okay. And then if they're allergic to that, then they can take Plavix. All right, Plavix is an antiplatelet also. They're having a STEMI, they're getting some beta blocker. Why are they getting the beta blocker? Metoprolol, low pressure. Not for blood pressure. They're getting it to reduce the heart's oxygen demand. How does it do that? By reducing the rate some, because it's blocking the beta cells around the heart, which have to do with rate control. Okay, so if I can take that guy's heartbeat down from 100 to 85, that's 15 less beats a minute while he's having a STEMI that is asking for oxygen. Okay, and the beta blockers have also been shown to do a couple of things. One is they prevent the subsequent heart attack, like 6 months or 6 years now, from being fatal. They've also been shown to help encourage some of this remodeling that's done to the heart as it heals up. All right. But the main thing is let's get that oxygen demand down. Now, depending where you work, as far as what other anticoagulants are getting, there's many choices. It all depends upon your cardiologist, your ER doctor, your local practice pattern. So the ENA is never going to ask you to pick, Lovenox, Fragmin, Integralin. All right. Just know that all of those are fair game, even when this person's going to the cath lab. Okay. For example, when I used to work at the university hospital, if you got admitted to the cardiology residence, they were doing old school heparin. If you got admitted to the private cardiologist, you were getting your low molecular weight, like the Lovenox or the Fragmin. It just depends on the service. But I do want you to know for the CN exam that either of those are, actually all three of the, any of those three families are eligible choices. Okay, it just depends, and you do not need to know the dosage. So there's our standard. If we know we can't get to the cath lab in 90 minutes, then we need to set a second timer and say, hey, can I get TPA in 30 minutes? And then I'm still sending to the cath lab afterwards. Okay. Same TPA that we use for brains. So the same contraindications for bleeding and et cetera. Okay. So of all the thrombolytics we have, okay, they all end in ASE. Okay, only one of them is a one-time push by syringe, meaning you draw it up in a syringe, you IV push it over a couple minutes, and you're done. This is the one that does not require a pump or running infusion. And so this makes for a good test question because it's the only one. And that will be our T&K or tenecteplase. One time IV push, no pump needed, no running infusion to calculate. So this is kind of nice for some of those other hospitals that ship their patients out because it's one less medicated drip the patient has to have during transport. Makes it a little easier on the transport crew, especially like if you're flying or something. It's one less pump or one less channel or cassette you have to put onto the IV pump. One less drug to have to monitor. All right, after the cath lab, they're going to go to some type of monitored unit. We need them on bed rest. Again, keeping that oxygen demand down. The heart is healing, it's trying to recover after they did their stenting, or let's say it was so bad they had to obviously bypass surgery. You don't want them up walking laps yet. All right, and there's your beta blocker again. And this will be the long-term one they're going home with now. To keep that cardiac remodeling, or to encourage that cardiac remodeling from the damage, to reduce the oxygen demand, to kind of keep things kind of chill as far as the heart goes. And some antithrombotic like the aspirin, the Plavix, the ACE inhibitor is kind of a plus or minus kind of thing, but for sure the beta blockers and the aspirin. Prinzmetal's angina. So this is still an angina. It's still an ischemic chest pain, but they don't have vascular disease. They're having most likely a spasm of the coronary. So as you see here, that vessel is clean. There's no debris, there's no clogs, there's no platelets, but it is still reducing the blood flow because it's narrowed. So we don't diagnose Prinzmetal's angina in the ER. We treat them just the same. And they can have the exact same symptoms, that crushing substernal chest pain, radiating to the left neck, the jaw, down the arm, nausea, because it's still an ischemic or pre-injury type pain. Oh, I'll go ahead and say this also. For all your body tissues, your ischemic time is about 4 to 6 hours. Okay. If there's an ischemic process, whether it be a heart, a brain, a testicle, the mesentery, that ischemic tissue is going to be getting that person's attention usually within 4 or 6 hours. Okay. You don't even memorize that, like it won't be an exam, but that connotates that, like when we talk about the torsion, you don't sit at home with the testicular torsion for 6 days. All right. Because that's ischemic dying tissue in about 4 or 6 hours. Now, the Prince-Mills angina, still the same progression. It's ischemia, thought to be associated a lot of times with stimulants. So like cocaine, even prescription stimulants like diet meds, the ADD meds, those kind of things. The cardiologist will determine this because in the cath lab, they'll see that the vessels are clear. But we'll treat them just the same as far as getting their workup going. You know, we may have some clues that it's maybe some drug use or something, when their tox panel comes back, but we won't know because we don't do the heart cath in the ER. Okay, talk about the right side of the heart here. And this is important because it's going to start to set the stage for some discussions about heart pressures and how things work, because the right side works a little bit different. Question is that also with Takotsubo? I would have to look at that to answer that definitively, and I will get back to you on that for sure. Okay, Art, if you're going to have an inferior MI, you can have it by just having one of these two distal branches occluded. So wherever the occlusion is, that means everywhere below there will infarct. Okay, so given the choice, if you're going to have an inferior, you would say, oh, I just want it way down here. So only a little bit is affected. But a third of the time that we see the inferior, we're seeing that zone affected because the blockage is not off on these distal segments, but it's off the RCA main. And when the blockage is on the main, it will affect the distal ones. And guess what? It now affects also where it goes around to the back side of the heart or the right ventricle. So 1/3 of the time, your inferior MIs are associated with a right side infarct also. And this is important because your right side of your heart is very dependent upon preload to sustain itself. So how do we know that the right side is involved? We're going to do a right side EKG, and we're going to look at lead V4R. The other way to say this, if you use the apostrophe, is V4 prime. Okay. So let's look at how we do this. So your normal left side EKG, we all know how to do that. We're going to take the chest leads and put them on the right side, the mirror image. We use the same landmark terms, we just substitute the word right for left. So your left side EKG, V1 goes on the right sternal border, fourth intercostal space. Your right side EKG, V1 goes on the left sternal border, fourth intercostal space. Okay, the other ones are placed the same. All right, V2 goes on the right sternal border, V4 mid-clavicular line, V6 mid-axillary, and then V5 and V3 halfway between those other ones. Okay, you do not need to adjust the limb leads. All you do is change the chest leads and make sure you label them correctly, that they're on the right side or that little apostrophe or prime symbol. And so V4 is the most useful lead to see that right ventricle. And this is why. So this picture is showing you a person that we sawed in half, and we took their top half off, and we're looking down into their, like down towards their feet. All right, and you see the breastbone, the sternum for your frame of reference. These leads would be the normal left side placement of the chest leads. And it shows you with the arrow approximately where they're looking at the heart wall. When we take these leads off and put them on the other side, you now see V4 is the most useful one to look right at that right ventricle. Okay, so that's a good test question. V4R or V4 prime, most specific lead for right side involvement of the heart. Now in EMS world, a lot of times we'll just take off V4 on the left and just put V4 on the right and just shoot it with that. We don't always move all the chest leads. That's not best practice. It's just a quick, easy thing to do sometimes. Best is to actually move all your leads over to the other side there. All right. So this is a real life example. Now, this part of the slide is marked up from another lecture. What we're looking at here is we got to look for the inferior first. And so I think we're all agreed. We've got some ST changes here in 3 in AVF. That's 2 boxes out of my inferior zone, which is 2, 3 in AVF. I've got 2 of the 3. That makes my inferior criteria. But now this is a left side EKG. So look at V4. V4 looks fine because it's on the left side. But I'm thinking, do I need to consider the right side also? Because I know a third of the time, this inferior has a right side component also. So this is the same patient. The next slide is the same patient with an EKG done on the right side just shortly after. So what you'll look at is look how V4 changes on the left side one to now V4 on the right side. You've got this obvious ST change there. That's telling you the right ventricle is involved also. Now, there's other stuff in ZKG that's not part of the talking points. This is all we're doing is I just want to show you how that V4 changes. All right, I'll go back one slide and we'll look at the original one. V4 is looking normal, no problem there. I've got my inferior component. All right, let's do a right side EKG and let's watch V4 again. There we go. See that change there, okay? So the reason we spend the time talking about this, because there's a little more I'm talking about than is in the book there, is getting to this point here. Starling's law says that any container that can stretch, has a point of maximal rebound where if you stretch it enough, it gets a good ejection or it squirts out good. If you don't fill it up enough, it doesn't squeeze out very well. If you overfill it, it's kind of weak. We don't want you over distended. There's a magic certain number that a certain amount of filling and stretching gets a good output. And we're talking about the ventricle, all right? So preload is how much stretching is occurring when the blood is coming in that right ventricle, okay? And this is the concepts we want to know. Feel free to screenshot this stuff. If you know how to do that with your Windows computer or take a camera shot or whatever, feel free to screenshot any of this stuff you want. I don't mind. It's all publicly accessible. So you need to know preload and afterload. And the reason you need to know this is because if you understand these two concepts, then you can answer many questions about heart output dynamics, what to treat, what not to treat, what to take away, what to add to, okay? Make it very simple for you. Preload means 3 basic things, all right? And this is like, a lot of people, it's like, this is like, well, because we're going to come back to this 2 or 3 times between today and tomorrow in different aspects. And I know from other classes, people still kind of get a little bit stumped on this and they have to think hard about it. Just take a moment and remember, preload means 3 things. Preload means, first of all, preload affects the right side circulation, so the right side of the heart. Preload is managed by fluid. Okay, if you need to increase preload, you give fluid. If you need to get rid of preload, if you have too much preload, you get rid of the fluid. And preload is also reflective of the venous system because the venous system is on the right side of your circulation. All right, so preload again means fluid, venous, and right side of the heart. So if I need to boost their preload, I give them some fluids. If I need to take their preload away, they've got too much, they're over full, I get rid of them like diuretics, like our CHF patient. A CHF patient has too much preload, they've got too much fluid. And then the afterload reflects the left side of the heart. And it means 3 things. It means the resistance, which is also your mean arterial pressure, as demonstrated by this little valve here. So this person, if they have hypertension or their blood pressure is up, it's too tight, there's more afterload. Afterload means blood pressure. Afterload means left side of the heart. And afterload means the arterial system. So a person with too much afterload could be having a hypertensive crisis. A person with not enough afterload would be hypotensive. How do I manage afterload? So I can either increase their afterload, I could increase it if they're hypotensive with a vasopressor. I could decrease their afterload if they're like in a hypertensive crisis, which is your fill in the blank here. I could decrease their afterload with a vasodilator. So basically one side is working with vascular control with a vasodilator or vasoconstrictor. The other side is working predominantly with fluids, either giving extra fluids or getting rid of fluids. All right, I'll say it one more time, summary. Preload, right side of the heart, venous system, volume or fluid dependent. Afterload, left side of the heart, arterial system, blood pressure dependent. Okay, so we're going to take these two concepts and use them for treating some of our patients. So going back to the right ventricle for a minute. Most of our heart attacks that aren't involving the right side, we can work with the afterload. If they're hypotensive, we can give them a vasopressor if we need to, or increase their output. For the right side heart failure patient, right side is damaged, that right side muscle wall, that right ventricle is infarcting, so it does not have the same ejection as it normally should. All right, so that means it's not getting enough blood out of the right ventricle up to the lungs, which then comes back to the left side and out to the blood vessels. So the right ventricle MI, that wall is damaged, I have less ejection, which will result in a lower blood pressure. Okay, how do I increase their blood pressure? I don't put them on a vasopressor. A vasopressor works on the afterload. I'm not trying, their problem is not afterload. Their problem is they don't have enough preload to get the blood out. How do I give preload? I give fluids. So for my right side MI, my right side heart attack is having a perfusion problem, they're hypotensive, I don't give a pressor and inotrope, I give small frequent fluid boluses. What is my fluid doing? It's trying to artificially stretch this a little bit more. So when I stretch it, it gets a better ejection out of it. Okay, so right side MI needs a preload boost with fluid. Okay, there's other things we can do. All right, I could start an inotrope. Inotropes increase cardiac output, but the drawback to those you must be cautious with is it does also increase oxygen demand of the heart. And if the heart is infarcting, I gotta be very cautious to how much I'm making it work there. All right. I could try and give them a vasodilator to reduce that workload, also the afterload. The problem with these, especially in hearts, is I gotta be careful. I could eventually bring their blood pressure down so much that now the coronary arteries are not perfusing. I'm going to be careful with Lasix, morphine, and nitro. Lasix, morphine, and nitro are your three standard, need to know these, memorize these, your three standard preload reducers. Okay, so while giving fluids increases preload, giving Lasix, morphine, or nitro decreases preload. Right side MI, right side ventricle patient, needs fluids, needs preload. CHF patient doesn't need preload. We need to get rid of it. That's why we give CHF person Lasix, morphine, and nitro. Okay, so just look at these two parameters here and tie them together. So something to decrease afterload would be a vasodilator. Remember, afterload is going to be that left side. I play with the afterload by adjusting the blood vessel. Okay, I play with preload by fluids or lack of. So if I need to reduce the afterload, I do a vasodilator, something like nitro, nipride, several choices for that. That's, 10. Okay, we're going to take 10 minutes here. We'll come back and do the last couple of heart things, then do a few vascular things. And then we got to talk about A lines, art lines also, because it's an intervention for cardiac. So we'll take 10 minutes here. And when we finish cardiac, then that will be the 30-minute lunch or dinner break for us. So let me do a little timestamp here. I will look up your question. Hang on. All right. Back on track with cardiac stuff here. So we're going to move into the heart failure. All right. So the number one cause of congestive heart failure is long-standing high blood pressure. All those years of working harder and harder against that afterload, their hypertension, makes that left ventricle work harder. Okay. The emergency presentation for left side congestive heart failure is that pulmonary edema, where that fluid backs up to the lungs because it can't get out of the heart. Okay, it can't get out, and so it backflows to where it came from, which was the lungs. Now, we can also have a right side heart failure, okay, and a person getting right side heart failure, I'm gonna come back to my heart picture here. All right, left side heart failure, the typical congestive heart failure is a left ventricle problem. It's weak and the blood can't get out, so it goes back to the lungs. It reverses. Right side heart failure, okay, it's a problem with the right ventricle. The blood can't get out. Where does this blood normally go? It's going towards the lungs. And for years, this right ventricle has been pumping against pulmonary hypertension. Pulmonary artery hypertension is the underlying common etiology for right side heart failure. All right, systemic hypertension is the etiology for left side. Pulmonary hypertension, and that's usually due to them having some chronic lung disease like COPD or emphysema. In this case, the blood doesn't back up to the lungs. Heck, it can't get there. It backs up where it came from. The blood in the right ventricle came from the venous system, came from all your, your blue veins, your venous circulation. So that's where the right side backs up to. And that person, they don't get pulmonary edema because it can't get to the lungs. They get all over fluid, and that's called anasarca. Okay, anasarca is not, left side heart failure gets dependent edema in the legs. Right side heart failure gets all over edema, and the medical term for that is anasarca. They're literally puffy and bloated all over because the entire venous system is backing up. All right, so summary: left side, chronic hypertension, pulmonary edema. Right side, chronic lung disease, pulmonary artery hypertension, in their case, anasarca, that fluid backing up all over. The best way to tell about heart failure is to look at that BNP level, okay, very specific for that. You do not, like the troponins, you do not need to know a reference range, okay, and you do not need to worry about that. Some people have chronic, we've all had that heart failure patient. Oh, well, his level is, 1,000. Well, he walks around at 800, that's not gonna be on the exam. You're basically gonna use the BNP to maybe distinguish, is that bad looking X-ray pneumonia or is it CHF? That's where something like the BNP test comes in, okay? And BNP is basically an inotrope that is released under a low cardiac output state. It's trying to boost the cardiac output, okay? So there's you a CHF X-ray there. Now, without a BNP, how do I know that that X-ray is CHF and not pneumonia? Okay, well, I got some clues, but I'm probably going to need the BNP to tell me for sure. The first clue, this could be pulmonary edema because I've got heart enlargement. You don't get pulmonary edema without heart enlargement, okay? So this could be CHF. Now, is it possible that a CHF person could have pneumonia also? Yes. So I would sort this out by getting a BNP. If the BNP is up, I'm saying this is pulmonary edema. If the BNP is normal, I'm gonna say it's pneumonia. Now, hopefully the rest of the story would have told me also, like they're having some cough, some purulent sputum, some fevers, chills, and I'm leaning towards infectious also. But that's how we use the BNP, is kind of separate these two things out. Now, the best test would be to tell me about the heart's ejection capacity. So an echocardiogram would tell me that. Your normal ejection is about 55 to 60% on a healthy heart. You don't want 100% ejection because then you'd have no blood to squeeze out at all. But a healthy heart is about 55 to 60%. And then they stage the degrees of heart failure based upon what that ejection is. All right. My goal for all of these is to continue the work of the heart, maybe increase it some, but I need to reduce the demand upon it. Okay. So my diuretics. So we're talking about preload here, because this is our CHF patient, right? And CHF patient has too much. CHF patient has too much preload. So that's where my preload reducers come in. Okay. That was my Lasix, my morphine, and my nitro. Getting rid of that surplus fluid. It's a preload problem. Okay. Morphine works to reduce preload. See, if you guys have version 1, you may need to make sure that you change this. It should say morphine is the correct phrase. Morphine is a preload reducer. Okay. I think in version 1 it said afterload, and that was not a typo. It was just the spell checker missed it. All right. Morphine reduces preload by reducing volume. Morphine causes some venous dilation also. Remember, preload is your venous side. And of course, nitro works as a vasodilator as well too. DIG is a chronic maintenance medicine they're on for like long-term output enhancement. We'll talk about digitoxicity and some other things with it later on. That's not something normally we're going to use in emergency to suddenly pull them out of the clutches of death, but it's something they're on maintenance-wise. When we look at specific vasoactive substances, we need to look at the words specifically, all right? And because this exam is pretty precise and specific, if something is a vasodilator, that's going to affect predominantly the afterload side, okay? They're going to dilate those blood vessels. Remember, afterload is a blood vessel problem. Afterload's on the left side, so they're going to bring that blood pressure down that way. These are usually our alpha blockers because your alpha cells are on the blood vessels. All right. So if you block an alpha cell, it relaxes, it lets go of the blood vessel, and it doesn't get tight. It actually dilates. So clonidine is a common one you're probably familiar with. We give that to a lot of patients for hypertensive problems. A venodilator, the word veno meaning venous, that's going to remind us, oh, that's that right side situation. That has to do with preload. And that's one of the reasons why these medicines also work there. Not only does Lasix reduce some fluid, Lasix also causes some venous dilation, and preload is the venous side. Okay. And then if something is an arterial dilator, it specifically works on the arterioles only. And we got many options here. These are some of our most common ones and others. We got nipride also. Hydralazine is common in some of our obstetrical problems. Calcium channel blocker like the Cardine. So notice what I don't have up here. I don't have beta blockers here. A lot of times you got beta blockers for blood pressure. I want you to remember this. The primary, there's no beta cells on the blood vessels. Beta cells are only on the heart. The primary reason you give a beta blocker is to get reduced oxygen demand of the heart by rate reduction. Now, by bringing that rate down and decreasing its work sum, you do get a blood pressure reduction. But technically, beta blockers are technically not antihypertensives. They're more specific for cardiac output management, and as a result, your blood pressure changes. So when we're having a blood pressure problem, okay, a hypertensive emergency is two things. There's two criteria. It's not just the number above 140 or 90, but it's also if they're having symptoms or evidence of end organ dysfunction. Your end organs, okay, these are the organs that are damaged by blood pressure. So when we talk about, are they having symptoms of end organ problems, we're talking about the eyes. Hypertension damages the eyes with things like glaucoma and increased pressure. Are they having stroke-like symptoms as the brain might be being affected by the pressure? Are they having heart symptoms like chest pain? The heart is an end organ. How about kidney functions? The kidneys are an end organ also. So we have to look at their BUN and creatinine. And then if you're pregnant, the placenta and the fetus are considered an end organ also. So these are all the organs at the end of the line of the blood pressure that are being damaged or affected or made dysfunctional because of that high pressure. So in the asymptomatic person, it doesn't matter what their blood pressure number is. There's no number written that says you treat. It's all based upon number. And so you're going to treat someone at 141/91 super aggressively if they're having stroke and cardiac symptoms. Someone who's at 240 over 110, if they're symptom free, we actually don't even need to manage that because it's not the number that causes the problem. It's actually the years and the long-term damage that's occurring. So for the CE exam, I want you to take away the number and symptoms. That mandates treatment. Now, most people's high blood pressure is what we call primary or essential, meaning it is. We don't know why it exists. I mean, we have some evidence, lifestyle, other diseases, things like that, health risk, things like that. But for the most part, it's considered essential and you just can't fix it, okay? Usually if they go on blood pressure medicines, it's for life, all right? Secondary or treatable blood pressure, these are things that there's a specific insult causing that blood pressure to be up, all right? The pheochromocytoma, that's a tumor on the kidneys, on the adrenals, all right? And if there's a tumor on the adrenals, they're secreting a lot more epi and norepi than they normally should. It's like your patient's on an epi drip, all right, causing their blood pressure to go up. We fix their blood pressure with that by they have surgery. They have this tumor taken off their adrenals. If it's pregnancy hypertension, the treatment is to have the baby, okay? So these are all secondary to something else. You treat the something else, the blood pressure should stabilize. So the symptoms could be wide and varied, or it could be nothing at all. Silent blood pressure truly is a possibly silent disease. That's why some people, never go to a doctor, and finally when they do, when they're, 50, 55 years old, and oh, congratulations, you have hypertension. What? I feel fine. Yeah, well, it's been there for some time. But when they do have symptoms, the most number one often reported symptom is a headache. But that's not very specific for blood pressure, but it is the most common one. The tests we're going to do related to blood pressure will be per their symptoms. Okay, so if they're having a chest pain and hypertension, yes, I'm getting an EKG. If they're having stroke-like symptoms, yes, I'm getting a CT of the head. I would say the only one we're going to do that doesn't cause symptoms is maybe just checking their urine for the protein in the urine. Okay, protein in the urine can be the first sign of that systemic end-organ effect of that blood pressure. Otherwise, we're going to let it be. I know in the real world, we do everything for everybody. But in this perfect CEN world, we're going to go by symptoms and tests that are related to those symptoms. If I do decide that we need to treat this blood pressure, I've got a number and I've got symptoms. Got many different ways we can do that. It's all about reducing that afterload, right? Afterload means systemic hypertension. So we got nipride. We can put that on, titrate that to what we want. We might consider nitroglycerin if they're having chest pain with their hypertension, because that would give me the dual benefit of also relaxing the coronary arteries. As far as a beta blocker goes, remember I told you we don't give it to directly change the blood pressure. We give it to affect the heart, which then affects the blood pressure. But I want to be careful with the beta blockers on my chronic lung disease patients. The reason is you have beta 1 cells on your one heart. You have beta 2 cells in your 2 lungs. Okay. And your beta blocker meds are intended to be beta 1 specific. They're designed ideally to exert most of their effect on the beta 1 cells of the heart. But in someone who has chronic lung disease, their beta 2 cells in their lungs, they're kind of edgy. I mean, they've got chronic lung disease. Those beta 2 cells are being stimulated stimulated more often. All right. And so if I give some low pressor, metoprolol, labetalol, one of the beta blockers, I may get a heart response, but I may get some spillover to the beta 2s also. All right. And when you block the beta 2 cell, you cause constriction. If you think about it, what do we give for asthma and COPD? We give a beta 2 agonist. We give a beta 2 stimulant to stimulate a beta 2 cell to open it up. If I give a beta blocker to chronic lung disease person, I'm blocking I'm not stimulating their beta cells now, I'm blocking them. That's going to cause the opposite of the dilation and cause bronchoconstriction. So metoprolol or any beta blocker to a COPD person, they might start being a little short of breath, having a cough or having some tightness. So I'm going to be careful with beta blockers in those people. And definitely with my heart failure patients who have that poor output, I really don't want to take away their rate control. So I'd be cautious with those people. All right, hydralazine, it's one of the ones we might use for our preeclampsia and eclampsia. We also use MAG as well. We might use nipride too. But if you had to pick one, a good starting point for preeclampsia, eclampsia, hydralazine is good. Regitine would be a specific agent for that pheochromocytoma. Regitine is a catecholamine blocker. And when you have that pheochromocytoma, you have too many catecholamines. The adrenals are just secreting that epi and norepi just constantly. So we start Regitine, and it basically buffers and nullifies all this surplus epi and norepi going around. So Regitine for the pheo. And then aortic dissections, there's some preferred agents there. Aortic dissections and aneurysms, we get those from too much high blood pressure. I'll show you some pictures here in a few minutes. So we need to get the pressure down. But the benefit of the Inderal, Brevibloc, Esmolol is they also help to reduce the shear forces on that dissection. All right, so not only do they work on that heart rate to bring the pressure down, but they also decrease the tension or the shear force, hopefully to minimize the continued separation of those layers there. And then if we're dealing with our heart failure patient, we got our preload reducers, the Lasix or other diuretics, and that morphine. Remember, those are preload reducing agents. All right, so if we're going to treat this patient, we're talking IV. All right, the CEN, if you treat someone with their hypertensive crisis, PO, it's not a hypertensive crisis. The absorption of those PO meds is not predictable. If you end up discharging them, you don't know what the rebound effect is. For this exam, we're talking they get admitted, they go on a drip, they go on a monitored unit. And look at that change. We're not going to drop these pressures quickly. Only 20 or 30% over 2 or 3 hours. So it needs to be slow and gradual. Okay. And treating to the number and the symptoms. So I don't care if you got that blood pressure down to 120 over 80. If they're still having chest pain related to it, we need to get that down further. I can't really stress anything more other than the take home here is it's numbers and symptoms is one of the big discussions here. All right, your endocarditis. So this is a problem with the lining of the heart and the valve. And basically the heart valves are a tissue type of the same lining. Although classically, when we do discuss endocarditis, we're more focused on the heart valves themselves. And it has to do with something either infective or foreign getting on the heart valves and making them dysfunctional. So to get endocarditis, you have to have some potential or portal or some way that something got into the circulation. So the risk factors, you see things like implanted medical devices, IV drug use, of course, things like that. Your heart valves, two things here. Your heart valves and your joints are magnets for foreign material to get on. Okay, so you think about like septic arthritis, these septic joints, when we talk under ortho, you're going to again see these same risk factors. You should not get a septic joint normally unless there's some risk factor or something to get in you. Okay, so some foreign or infected material on the heart valves causing dysfunction. And one of the big concerns here is that those valves are not functioning, like they're not closing completely or they're not opening as easily. It can lead to things like some heart conduction changes, some heart failure. Now, it's not going to happen immediately right away, it'd be gradual over time, but untreated endocarditis can cause some of these other problems. On physical exam, there's not really anything useful on physical to say, oh, it's endocarditis in general, but we do have two characteristics that are pretty specific, but we just don't see them that often. One is Janeway lesions, and the other is Roth's spots. So I've got pictures for you of those. So both of these have the same cause. And what they are is small emboli coming off those heart valves and going downstream to the small circulation and causing these little inflammatory kind of infarcts, if you will. All right. Now, Janeway lesions can be on the test. Ross spots, probably not, because to see Ross spots, you have to examine the back of the eyeball, and that's mostly providers, not staff nurses. But Janeway lesions you can see just by looking at the palms. All right, see multiple little erythematous or red and inflamed areas, and basically that's those emboli showering downstream. Both of these findings, both these physical exam findings are pathognomonic, that word there, pathognomonic. That word means exclusively related to that condition, meaning no other condition other than endocarditis has Janeway lesions. So if the exam says that somebody has Janeway lesions, you can almost go right to the answer and pick, oh, endocarditis. So pathognomonic means exclusively associated with that one condition. The most useful test, now an echocardiogram would be very useful because they could actually see the heart valves. But before we get to that point, we want a sed rate. Like I just said, your valves and your joints are magnets for particulate matter or infection like that. Also know that if something is on your valve or joints, there's inflammatory markers that are released. Okay, so for endocarditis, we need to add a sed rate on, and it's going to elevate. Again, echo would be the best test, but a lot of times before we get the echo, because we're not even thinking about it, right? They're just kind of not feeling good. Maybe we've even done some septic workup kind of stuff, because they don't always come in with chest pain with endocarditis. Okay, but if that sed rate comes back and they've got the risk factors, you can bet someone's ordering an echocardiogram on that patient. Treatment is basically high dose anti-inflammatories. Yes, they can act, depending how much their cardiac function is affected by this, they can actually admit these. There are IV steroids we give, things like that, and then serial echocardiograms to see the progression of it. If it's infective endocarditis, of course, antibiotics and blood cultures. Your pericarditis, so while you can have an infective pericarditis, that is the least likely thing you'd ever think of. Almost all of them are just inflammatory, okay, and idiopathic. We don't know why they get this. All right, they'll present with some chest pain because as the pericardium is getting angry and irritated, it's affecting their heart. And one of your giveaway symptoms is chest pain, and you always ask them, what makes it better, what makes it worse? It feels better when they lean forward. Okay, that's a textbook symptom, a textbook finding. We're gonna get that EKG because they're having some chest pain. And this is your other giveaway. Anytime an EKG shows ST changes all over, globally, diffusely, anything that connotates the entire surface of the heart is angry, we got to think of pericarditis till proven otherwise. Okay, so because you're not going to have an infarct in all the leads, in all the zones. Let's face it, you'd be dead. All right, but when you see words like diffuse ST changes, global ST changes, you got to think about pericarditis, because we're trying to measure, you know, the EKG electrodes are on the chest, and they're trying to measure the electricity of the heart muscle through this pericardium that's getting thicker and thicker and thicker. So it's getting fuller. So it's more difficult to measure the voltage. We're going to see these blunted or dampened or decreasing amplitude, all right, of all the waveforms. Why all? Because pericarditis infects the entire pericardium. It doesn't affect one zone. It's going to affect all of that membrane. So all those leads. So if we do find it, and again, we'll get an echo for this to see the degree in how much effusion's there. If we're going to treat it, it's going to be high dose anti-inflammatories or steroids, because remember, it's almost exclusively inflammatory. And of course, if it is too much, then they may do a pericardiocentesis, which means to remove fluid from the pericardium. Whether we do it emergently with a large needle and an ultrasound to guide it, or if the patient's stable and they do it in specials or in the OR, and make like a little, they'll go in under the endoscope and make a small incision, a little pericardial window possibly. But the treatment is to get the pressure off. Now, Beck's triad is a grouping of 3 findings that indicates we're looking at cardiac tamponade, which is our emergency. All right, Beck's triad, you need to know this. Jugular vein distension, because as that tamponade is starting to happen now, the blood cannot come out of the jugulars back to the heart. So you start seeing the neck veins distend. They will be hypotensive because the blood can't get out of the heart. And we will have muffled or dampened heart sounds. Muffled or dampened heart sounds. If you ever see that word muffled, dampened, or distant, that's kind of a clue. Ding, 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 ding. You probably have cardiac tamponade. All right, so no Beck's triad for the test. So this person's hypotensive and the blood isn't getting out of the heart. That's why they're dropping their blood pressure. This is one of our shock types. Okay, this is one of our obstructive shocks. And the reason it's obstructive and not cardiogenic is because the way the ENA classifies your shock types, which we'll talk about tomorrow, is the classification connotates what the problem is. This is not a problem with the heart muscle. Cardiogenic is a muscle problem. Obstructive is something that's restricting it. In this case, the pericardium, which is not the heart muscle, it's restricting the outflow of the blood. And also, the different classifications of shock tell you what you treat. In cardiogenic shock, you treat the heart muscle. In obstructive shock, you relieve the obstruction. So if cardiac tamponade, the obstruction is too much fluid, the treatment is to get that fluid off. So again, Beck's triad again for you. Muffled heart sounds or distant, distended neck veins or JVD, and the hypotension. Looked like it was spelled wrong for a second. Pulsus paradoxus, this is a finding associated with cardiac tamponade. This kind of defines cardiac tamponade. What you'll see is the systolic blood pressure changes by 10 points between when they breathe in and when they breathe out. It has to do with the chest wall getting bigger and putting more pressure on the heart. Now, realistically, you don't look for pulsus paradoxus unless you think you have cardiac tamponade happening. Okay, if you think you have cardiac tamponade happening, do you think this patient can take a breath, hold it, and let you measure pressure, and then blow out and let you measure pressure? No. This is seen typically in the ICU setting where they're already admitted for this, and they're critically ill, they're on a vent, and they've got an A-line, and we can see that pressure change from each ventilator cycle. So not really useful in the ER setting, but it is a specific physical assessment that is correlated with cardiac tamponade. And as discussed, we need to get that fluid off if it's to the point of tamponade, whether it's done emergently with the guided needle ultrasound, or if they go to the surgery and do like a pericardial window on the more stable patient. Our blunt cardiac injury, they've taken out the word contusion. We don't call it cardiac contusion anymore because that kind of makes, it's just a bruise, not a big deal. It can be so much more than that. That bruise, because the bruise on the heart muscle wall, that part of the heart muscle may be dysfunctional, and you may actually have decreased output. So we call it more cardiac injury now. Your most common mechanism is some frontal impact, whether it be a steering wheel, sports like a baseball, sports like a karate kick to the chest, something hitting that anterior chest wall. And the part of the heart that's damaged is the anterior part of the heart, and also a little bit of the inferior, because the way the heart sits a little rotated in the chest, those are the two parts that are exposed if there's that blunt force to the front of the chest there, okay? And that's where we'll see our EKG changes, okay? The anterior, and then sometimes the inferior leads also. And how I know it's not a STEMI, because the history, patient will probably have some cracked ribs up there, bruised on the chest. EMS says, yeah, the steering wheel is deformed, okay? So they're not going to tell you just a person has anterior, inferior ST changes and you think, oh, STEMI, they have to tell you the rest of the story. There has to be some trauma here. This picture is also showing us the one of the reasons for a sudden cause of death in these anterior chest impacts, because as that heart comes forward, it can shear on the aorta and the aortic rupture. And of course, you're not going to perfuse, but about a minute or so if you tear your aorta. So some of these patients don't even make it in to see us by EMS. All right, peripheral vascular disease, which is also called PAD, or peripheral arterial disease. This is atherosclerosis of your extremities. So instead of you having coronary symptoms or stroke symptoms with atherosclerosis, you're having peripheral symptoms. Risk factors are fairly similar to we talked at the beginning of the cardiac lecture, because remember, atherosclerosis doesn't just go to one area. It can affect all your vascular system, but this is when they're having specific symptoms for the periphery. Now, Raynaud's is the Prinzmetal angina of the peripheral circulation. So whereas Prinzmetal angina was that spasm causing decreased coronary flow, Raynaud's is a spasm causing decreased peripheral flow. And they can get ischemic digits, things like that. The trigger for this is usually or commonly in people that go from a warm environment to a cold environment. And that sudden clamping down the blood vessels, and they stay locked down. Buerger's is more the typical atherosclerosis, where they actually get some clots and some inflammatory mediators parked or lodged distally, so it can still cause decreased flow. Yeah, and there can be a genetic component to Raynaud's also. And there are actually cases where people have lost digits from not being able to reverse the ischemia and actually get infarcted digits. And that's a disease of triggers too, by the way. Intermittent claudication is the angina of the extremities. So when we talk about the heart and we talk about angina, we saw chest pain with increased oxygen demand, and it gets better with rest. Okay. When you have PAD, you get leg pain with increased use, and it gets better with rest. Because when you're using your legs more, like climbing stairs or mowing the lawn, your leg muscles are asking for more oxygen. And if you've got some narrowing, you're going to start getting some of that ischemic kind of pain. Hopefully that's still reversible early on. So intermittent claudication just means the same thing as angina, but we're talking about this extremities. Other things we'll see, we'll look down their legs, and we might notice some like that bronzing, brownish kind of color where they got that chronic insufficiency going on. We might notice some poor healing wounds, some ulcerations. We might notice there's no hair on their toes or feet. And not because they shave, but because actually the blood flow is so restricted, it's not even allowing the hair follicles to grow. And trying to assess the circulation on some of these patients can be pretty difficult. Trying to use like our pulse ox probes sometimes, your ultrasound stethoscopes, maybe even an actual echocardiograph, some type of ultrasound device, trying to see the actual blood flow can be very difficult and impaired there. Our job, just like the patient having angina, I don't want the patient with angina to walk back to the treatment room. I want a wheelchair, and I roll them back so I'm not increasing that workload. Same thing here. Okay, I need to reduce their activity to encourage that that imbalance in oxygen supply and demand. Keep them warm. Okay, especially if it's like Raynaud's, you want to keep them warm too. The providers will decide, what people need, like angiograms, what people need other type of vascular studies to see the degree of their atherosclerosis, and doesn't need to be dealt with by a vascular surgeon. So that's kind of not what we're going to be worrying about. We're going to just try and encourage and maintain that perfusion and not obviously make it worse by having more oxygen demand. So that was the chronic disease of having just this chronic impairment. Arterial occlusion is when we get that sudden lack of blood flow. Now, they could have atherosclerosis also or not, but the difference here is you're actually infarcting something now. So this will be kind of that short-term pain, like that 4 or 6 hours. Something is just blocked an artery in the periphery. Now, that blockage, usually comes from what we call a thrombus in situ. All right. What that means is it's talking about up higher, like around the aorta, they will usually find a debris field of clots, plaques, and debris that aren't causing a problem in the aorta because the aorta has a bigger diameter. But one of these pieces comes off and goes downstream to the small vessel and blocks it. That thrombus in situ means basically ticking time bomb. It was waiting to happen. All right. And when vascular does go in and either open these or bypass them to get the flow restored, if they see this thrombus in situ up, they'll actually deal with it also, clean it up, debride it some, so it's not a risk for later problems. But it's just saying it came from somewhere. It didn't just spontaneously generate. DVTs, so this is on the venous side of things. All right. The risk factors here are not atherosclerosis, but anything that makes the blood want to clot, all these hypercoagulable risk factors. Smoking, hormones, being pregnant, recent cancer, or I'm sorry, recent trauma, surgery, cancer. All these things, immobility, all these things promote blood clotting. And they're going to typically arise in the lower venous system. And of course, our concern is to not let it become a PE. So, DVTs, no one dies from a DVT, but the fact that you have a DVT suggests you could have a PE if it breaks off and goes upstream. So they're going to present with one-sided calf pain, maybe warm, swollen. All right. Could look like cellulitis. I mean, sometimes we're trying to decide which one it is. We've got to get that ultrasound, right? So the D-dimer test. So let's talk about who needs that. So D-dimer is very sensitive, meaning it does a very good job of elevating when you have a blood clot, although other things can elevate it too. So it's not that useful to be specific. Think of another test you're more familiar with how this works. Think about your CBC. And the CBC comes back and you look at the white blood count. Okay. Oh, white blood count's 20,000. Does that mean it's an infection? No. What other things could cause that to go up? Well, infection, high dose steroids, dehydration. So while the white blood count going up is very sensitive to an infection, it's not the only thing. So let's translate that to the DVT. The way I want to use the D-dimer, I want to use a D-dimer when I only want to do one test to get a person out of my ER and send them home, and it's a reliable test and less expensive, less time consuming. All right, so I'm going to do this on the person who I think, well, it could be a DVT, but they don't have any of the risk factors. So let's do it. It should come back 0, and I can send them home and say, we're done. So maybe help to differentiate if it's cellulitis or not. So you do it on the safe, stable, low-risk patient. Okay. If a person comes in, they're having one-sided calf pain, swelling, it's warm, they smoke 2 packs a day, they're on birth control, they just had elective surgery over in China and took a 12-hour plane ride, I'm not doing a D-dimer. I'm doing the ultrasound because they've got all the risk factors for it. All right, so we use D-dimer to rule out, not to rule in. So we treat the DVT to prevent a PE because that's where it's going to go upstream possibly. And they're going to go on some anticoagulant. Again, just like the guy going to the cath lab, I said you could pick whatever you want, Lovenox or heparin. Same thing here, it just depends on the provider. You don't need to worry about the dosage. And as of right now, Coumadin is the only anticoagulant on the test. All right, the newer ones, the Eliquis, the Pradaxa, they've not found their way to standard practice yet to be on the exam. And the nice thing with the Coumadin is we can actually measure its effectiveness. All right, and INR of 2 to 3 means that means their blood is going to be 2 to 3 less likely times to clot. So how does the DVT get removed? Okay, because we're not giving them TPA for it. The Coumadin is just to make it not get bigger or to minimize the likelihood of pieces going off and going downstream, right? Our bodies have enzymes. Our bodies have anticoagulant built into us. we slow down the progression of the DVT, and over time, my body's own enzymes will actually degrade it. Okay. Now, if you're taking Coumadin prophylactically, yes, you're making the formation of DVT hopefully not to happen, or hopefully not for a clot to get formed in your atria if you have a chronic AFib. But they're not actually lysing the clots. They're just making them, preventing them from getting bigger or traveling or extending. The aneurysm, this is a stretching or a dilation of an arterial wall. So I'm showing you a picture here. It looks like a wash machine with a couple of hoses, and you see that big bulge on the side. That's because there's too much pressure in that line, and over years, eventually that pressure stretches it. So aneurysms are usually asymptomatic. Patients don't feel it. They don't know they have it. It's if you're having pain, then we think dissection. Matter of fact, a lot of aneurysms we just find randomly. Patient comes to the ER, oh, I'm having a cough. Oh, let's get a chest x-ray. And we see this wide mediastinum, and that can be a clue, okay? Wide mediastinum just means the area above the heart where the great vessels are, it's wider than it should be. And it could be wide because this aorta has a big bulge around it. You can't tell on x-ray. This person has to go back and get a CT now, okay? But we can identify this widened part here. Well, that's a textbook finding that opens the door to an aneurysm. Now, the CT will then tell us, well, are they, how much of an aneurysm is it? Is there any narrowing or stenosis occurring? That will determine if they need some surgery or not. It may be stable, and they get to go home and follow up outpatient with cardiothoracic surgeon or vascular, or they may already know about it, and they might do the CT scan to see if there's any progression from a previous scan or whatever. If they do have surgery for it, basically they're putting a stent in there of types to support, stabilize that wall, and reinforce it. So the bulge of the aneurysm typically occurs at more than one place, and in some cases it will actually stretch down, going down the aorta. So look kind of like kind of knobby and kind of bumpy going down there. And then we can have one in the abdomen also, so it'd be a thoracic or an abdominal aneurysm. But the key thing here is usually asymptomatic, and look for that history of blood pressure that's been uncontrolled for quite some time. Now the dissection becomes the emergency, all right? Number one risk factor for this is just age and probably a pre-existing aneurysm, because that aneurysm caused a weak spot. The word dissection means to separate as these two tissue layers start to separate. And this is one of those times that we use that kind of unconscious key phrase of, I feel this tearing or ripping going on. All right, if anybody's having chest pain and they pick one of those two words, tearing or ripping or through to my back, we want to really quickly be evaluating those patients. It's just an automatic kind of word they say. So what you see here is, this is the dissection where it's separating, and they've done on the gross anatomy, they've taken 3 slices at different levels of the aorta. And you see as it goes further and further down the aorta, look how much more of that dissection is happening. Look how little blood flow is getting through here. If this person's in shock, that's an obstruction. This is aortic dissections are one of our obstructive causes of shock. What's the obstruction? The dissection. Relieve the dissection, relieve the obstruction. Okay. Now our concern here is with this expanding accumulation of blood and debris is the pressure it's putting on the outer wall. And the concern is that pressure is too much and it can rupture and break. And like I said, you don't perfuse but a few minutes if you rupture your aortic wall. As soon as we identify a dissection, this is the one time we treat that blood pressure immediately. And you don't do that slow and gradual 20 or 30%. Every other blood pressure, here comes one of those loud jets. I might have to be quiet for a minute. Every other hypertensive emergency, it's slow and gradual so we don't get rebound problems. This is the time, and there's, depends who you read and what your vascular guys like. Some say you drop them to a map of like 40 or 50 immediately, because you've got to get every bit of pressure you can off that wall, because you don't know if you have 5 minutes or 5 hours or 5 days that wall can hold, and they're going to immediately to surgery. This is where we like the Esmolol, which is also called Inderal or Brevibloc. So I in the book there I got beta blockers. If you want to put a little line and specifically put the Esmolol or the Brevibloc, again, not reducing blood pressure, but they're decreasing the heart force and the rate. But these Esmolol and Brevibloc have the second principle of it reduces some of the shearing force on this outer wall. That's why they're preferred. So given the choice, Esmolol or Brevibloc be one of the first two you pick. The other ones are fine too, because you do want the blood pressure down, but given the choice, one of those beta blockers is the best. Esmolol or Brevibloc. And this is showing you an abdominal one. Note the lumen getting narrower and more narrow here, impeding or obstructing that blood flow, so obstructive shock. All right. And the reason the walls dissect is because there's some break in the wall from all those years of hypertension with your aneurysm, and now there's a tear and blood starts filling in here, making the space bigger and bigger. Okay, each section of the blueprint has the potential for an intervention or two that are specific to that. So under cardiac, our intervention is arterial lines. This is indicated for any patient that's on something that's vasoactive. This would be your best care for measuring their response. Now, the ENA, they know that we're not ICU people. We know that we all don't drop A lines as soon as we start the dopamine or something, but that would be the best way to monitor it, is an A line. And so the only things they ask about these interventions are how we do them safely. You could do entire courses in management and measuring of arterial pressures and trending them and different therapeutics for them. All we want to know is what's the basis of getting it going, what are we watching for, and what are some things that can go wrong with it, okay? So one of the things about an arterial line, and this is for any arterial puncture, is we need to do Allen's test. Allen's test is a way to test both arteries of the hand and make sure they're patent, because one of the risks is with any arterial stick, you can permanently damage that artery, permanently. And some people only have one functional artery. And if you take away their other one, now they have no perfusion to the hand. All right, so to do Allen's test, you gotta do it twice on the side you're gonna use, because the first time you do it, you're just checking one artery. The second time you do it, you're checking the other one. You need to prove that both of them are patent. All right, and both of them, when you let go of the vessel you're checking, the hand should pink back up or back to their baseline, just like capillary refill. Should pink up really quick. Now, if you don't get a positive response to one of the vessels, you have to go to the other side of the body, or think about another site. Like instead of doing it radially, if both sides are messed up and they've got they got an abnormal Allen's test on both sides, then maybe look at the femoral artery. So the basics of setting this up is the transducer. That's the little plastic cartridge that usually goes on the IV pole and one of the little clamps, and it's got an electronic chip. And what it does is it detects the pulsation, boom, 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 the pulsation of the fluid in the tubing, and changes it to an electrical signal that goes to your monitor. So you can see the pulse, so you can see something that you normally can't see. You can see the pulsations and actually measure that pressure, all right? So transduce means to change from a pressure to an electrical energy source. And it goes at the phlebostatic axis, which is the fourth intercostal mid-axillary line. It's basically lined up with the atria, which is where things are zeroed at. So anytime your patient changes position, if they sit up, I have to move the cartridge up on the IV pole and make sure it's level again with that same spot. If my patient lays down flat, I have to move the cartridge down and re-zero it, make sure it's at the same horizontal place it should be. Of course, easiest thing to do is probably just to take the cartridge and tape it to the patient's chest. So anytime they move, it moves with them, right? All right, complications of this. So this is just a discussion in keeping things simple, all right? Again, the ENA wants you to keep it simple. Anything that go wrong with a regular vascular device can go wrong here. So simple answers like dislodgement, bleeding, disconnection, infection, things like that. Don't overthink this. Do not reinvent the wheel and think, oh, complication, there could be, it could be showing me this waveform and I have to do this or something. No, we always look for the simple, common things frequently. All right, dislodgement is much more likely than something wrong with the transducer. Okay. So can I go in the room and look at the monitor and know that things are working and we're good? Can I just be a safe practitioner? It's like when we all took the NCLEX exam. The NCLEX, when we passed it, did not say we knew everything about nursing. It said we could be safe providers. We knew enough to know things are good. And if we didn't know something, we were going to go learn about it or get some help with it. Same thing here. Is my A-line working? And there's three defining characteristics. One is as soon as the heart valves close and push the blood out, it goes up very quickly. So a rapid upstroke. And because the heart valves are asynchronous, they don't operate at the same time, the same moment, there's two peaks here. We call that a di, meaning two, crottic notch. Two crotches, I don't know. Two peaks, dicrotic, all right? And then as it releases the pressure between systole and diastole, it drops very quickly to an end point. So this is your good A-line waveform, up quickly, two peaks, and a definite end point. Anything that's not that is abnormal. If you have like rolling waves, you have shark fins, you have pyramids, those are not the normal functioning waveform, okay? Now, if it is not functioning, then we're going to do some things to troubleshoot that. But that's CCRN stuff. We're just going to get someone's help. Say, hey, can you come check this for me? All right. It'll be the same thing with the ventilators, y'all. Can you walk in and see the ventilators functioning? If it is, you're good. If not, you're going to get some help. All right. Those of you that have volume 1, you'll see there's some ACLS stuff in there. Those of you that have volume 2, you're not missing nothing, because every class for last year, I've had to say, that ACLS stuff is just for a little bit of reminder review stuff. I don't talk about it in class. Hang on, another jet here. Because that's something that you can get somewhere else. And the point of the class is to give you stuff that is not outward other class stuff. So for future classes, I took it out of version 2, so it's not even a distractor. So you're not missing nothing by not having it in there, volume 2 people. And volume 1 people, even though you have it, make sure you always reference your most recent sources as well too, okay? So that takes us to where I wanted to be for our lunch/dinner break. And let's see, so we'll take 30 minutes so you can actually put your feet up or do something for a little bit. Let me see what the timestamp here says. All right, and it says 12:02. My time zone, of course. So 2 minutes. I'm gonna make it 5 minutes after. So if you guys come back at 35, I'll stick my head back in here at 30. But if you need just a couple extra minutes, 35 at the latest, and we'll get started. And what section are we doing next? I forgot. I'll look it up while you guys are gone. I'll see you guys in about 33 minutes at the latest, all right? If you think of a question or something you need from me, just put it here. I'll look back in the chat box and see if there's something we need to address or whatever.